Welcome, everyone. My name is Bill Mahegan, Senior Program Manager for Carequality. This session is going to be about implementing FHIR. I had originally planned on giving you a bunch of background and some backstory on FHIR, but I think given this group, that would be largely a waste of your time. So I just wanted to let you know that we published version 1 of the Carequality FHIR Implementation Guide back in December of 2020. We are currently teeing up version 2 due to be published next month. However, we're still waiting for our first FHIR applicant. So what I thought would be a good use of our time today would be talking about how to get folks to participate in FHIR-based exchange, and maybe have some of our panelists give us some good ideas on how to do that, and maybe talk about their experiences implementing FHIR. But actually, before we get to that, one of the main focuses of our FHIR implementation guide is actually UDAP and client dynamic registration, and the fact that it would allow us to focus FHIR-based exchange at scale. So I'm going to have Dave Pike just lead us briefly through that, just to give you a sense of what it is and how it will help us stand up this ecosystem. And then we're going to start bouncing some questions off the panelists. You ready?
Yeah.
All right.
I have slides, so.
Yes.
Let's see how this.
Oh, sorry.
Oh, can't read ahead? All right. Whoops. Wow, it really does jump. Okay. Hello? There we go. Okay, so can you hear me? You can hear me okay, because I can hear myself. One of the big things we're dealing with, of course, is the scale of Carequality. And for most of you who work with OAuth, it's a very human-oriented process, right? You reach out, you get people saying, hey, I need a client ID, and they send you an email back saying, who are you and why should we do that? And so on and so forth, and eventually you get one. At the scale of Carequality, that's simply not possible, right? We're dealing with 45,000 different implementers and whoever, or members of the directory. It's not possible to do that on a one-to-one basis. It's just going to break the system. So we get together with UDAP, and as part of the FHIR implementation guide, we have required the use of UDAP to connect using FHIR. Now, this is based on the HL7 recently published FHIR IG. There's the long name for it, and it's been published just over the summer at HL7. It's an extension of OAuth 2, and what it does is basically take the OAuth flow and automate as many parts of it as possible, and allows for automation of the client ID and authentication token, authorization. All of it can be done without human intervention, which is what we need. If we're going to do this at scale, we got to take the people out of it. So let's look at the basic flow. So you start off with, you ask the FHIR server, hey, are you UDAP? Kind of straightforward. It tells you the information in the well-known /UDAP file, where to get that information. So what my auth server is, what parameters, what encryption routines, that kind of thing is part of it. You do the discovery request, you get the response back with all that information. Next step, you go through and issue a UDAP software statement. So that is a large bit of metadata saying who you are, who your organization is, why you should get a client ID. That information is interpreted. Once it's all got back, because you're going to use your Carequality information to say, hey, I'm doing this through Carequality, let me in. You get back a client ID. Next step, authorization request. And that gives you the scope, whether you want to lock it to an individual patient, if you're locking to specific things. It follows the standard OAuth scopes, and you can use that, again, to lock it down to individual patients, to individual organizations, everything I ever wanted, or pictures of your grandmother, whatever is on the server that you want. That is incorporated into the authorization decision, and what you get back is locked to that requirement, okay? Now, they may say, no, you can't have scope. You cannot have everything. You have to lock it to specific patients or specific organizations. That's a policy decision, but that will be handled automatically as well. Finally, you put your TEFCA extension in. and send it again for a token request. Now, if you're an organization, you put your user information. So I'm Dr. Bob. I'm here asking for information. I'm from Veterinarian's Hospital. I'm here to get information about X. If you're a user, you use the TEFCA user information. That's a typo. I should have fixed that when I copied it over. You use the Carequality user information, saying, I'm a user, here is my information, and we can, it will lock it to that specific patient record only. So obviously an individual user would only get an individual patient's record of their own, or someone they have authorization to access. Once you've got that, you get your token, and away you go. You can start making requests. Tokens have a limited lifespan. Somewhere between 20 minutes to an hour is generally what's used, because you don't want to give this forever. Tokens can be refreshed as necessary. Client IDs may have a specific lifetime. Again, if it gets too old, it hasn't been used, it may be deprecated, you go back through the whole process again. But again, it's all automated. So we're not sitting down, sending emails, making phone calls, sending paperwork. If you're on Carequality, we trust you. We have a trust framework, it's in the first name. And therefore, use that trust framework to say, yes, we can get this done, and UDAP makes that automated possible. So some of the technical requirements, because there are technical people here. It's RFC 7515, that's the basic JSON web signature. 7519, that's for JOTs. The JOT header in JOT claims, to the Carequality facility. I really didn't do a good job of copying that over. It corresponds to your Carequality ID. Shh, pretend it all says Carequality. Be digitally signed using the permitted signature algorithms listed. That's RS-256, ES-256, and so on. Include your certificate in the header itself, and be serialized using compact serialization of RFC 7515. I know, that was the exciting part. That's why I went over it quickly. And that's it. Back to Bill.
All right, thank you, sir. Let's see. So the next slide we have here, I'm just gonna briefly have you all just introduce yourselves, keep it to like 30 seconds if at all possible. I know you can go on forever about your accomplishments. And then we're just gonna start with the panel discussion after that.
Oh, I'm sorry. Okay. Well, all right. He already said who I am. I'm Dave Pike. I work for a company called Audacious Inquiry. We're a point-click care organization. I have been a standards architect for far too long, working with HL7, IHE, and miscellaneous other standards. I have been doing FHIR since the first release. I was part of the QA team on the first release of FHIR. And that's my 30 seconds.
Jason Vogt. I am the product owner of our APIs and structured documents at Meditech. I'm also the STIG chair for the STIG committee for Commonwealth, and I'm also on the steering committee for Argonaut and help write that UDAP specification that Dave just went over.
Hi, my name is Jennifer Blumenthal. I was previously the CEO and co-founder of OneRecord. OneRecord was just acquired by Milliman IntelliScript, and I'm the product director of OneRecord at Milliman IntelliScript. I currently sit on the steering committee at Carequality. I'm the chair of privacy and security at Commonwealth, and pretty active in the work groups across Carequality, Commonwealth, and the Karen Alliance, and now I'm on the board of the Sequoia Project.
Hi everybody, I'm Marilee Benson, president and co-founder of Zen Healthcare IT. We're a healthcare interoperability platform. I'm a member of the Carequality Advisory Council and have been doing this a very, very long time. I kind of stopped counting. And we work with a lot of customers doing a lot of data exchange and a lot of problem solving every day. And that's part of the reason why I'm on this panel, is looking forward to solving a different set of problems instead of the same problems we solve with IET-based exchange every day.
Hi everyone, I'm Labib Rahman. I am a product manager at Particle Health. Particle Health, if you are an implementer, you know how difficult it can be to become an implementer. So we build an API that allows you to connect to the frameworks and networks instead of having to become an implementer yourself. At Particle Health, I own the API that we provide to our customers, as well as our integrations with Carequality, Commonwealth, and eHealth Exchange. We'll pass it back to Bill.
All right, thank you. So obviously, we felt like UDAP and client dynamic registration is such an integral part of this implementation guide and about having the ability to stand up a FHIR-based exchange ecosystem at scale. So what I'd like to hear from a few of you are, like, how much time do you spend for your non-UDAP integrations? Like, talk to me about your FHIR API integrations that didn't use UDAP and how much time is consumed for that, and how you envision UDAP solving what we perceive to be such a huge problem. And Jenny, you can start. You're smiling. It seems like you're ready to serve something up here.
Are you going to start with all the emails you send every day? All right.
So I'm going to use Jason's organization as an example. I probably for the past 2.5 years, 3 years, have consistently spent from like 8 a.m. till almost 11 a.m. just working on registering. We call it, so for context, One Record enables consumers to access, aggregate, and share their healthcare data with the people and organizations that they trust. Our first implementation back in 2018 was to Carequality, and we were really excited, and then no one responded to patient access, but we'll talk about that later. So then we were like, oh, cool, fireworks, let's try that. So we connected to Epic via their, now Epic on FHIR, and we started going down the line to all the other EHR vendors. The problem with all the EHR vendors is they all have kind of a different flavor of their implementation of their registration process. So where maybe it's owned at a centralized location versus owned at the client level. So what's really difficult for me is I kind of now have a pattern that I follow is I go by vendor, I then stalk that vendor, and I figure out who the point of contact is within the organization that I need to harass, and then I email every single one of their clients over and over with the exact same template, and I timestamp it every day till they authorize our client ID so that when we query them, we don't get an error. And I mean, it's the same thing on the payer side of the CMS side of the rule. So it's very time consuming, it's a lot of work, and it's not scalable is the ultimate punchline to it.
Okay.
I mean, I'll jump in here. I guess, like, as Jenny said, like, for each organization, everybody's got their way they distribute clients and how they share their secrets. Everybody's got their own security around that too. How do you gotta do it through Zoom? You gotta do it via a very secure download, all these different things. So, like, it's very diverse on how people do this. And I think UDAP, the one thing I guess I want to point out here is that it's not just for Carequality, right? It's not just like, how can I use this in Carequality? Like, you could say, okay, how can I use this in my other networks? How can I use this individually, right? Like, for Meditech, we're looking at, okay, if we have, Greenfield Health Alliance and we've made these connections with these other vendors, can we distribute our own certificates so that when they go to our healthcare organizations, they can use that certificate to easily register, right? So not only am I scaling it in Carequality or am I scaling it in Commonwealth, I can just scale it individually, right? Jenny, One Record and Meditech have a relationship. We've done our vetting, we've done our testing, we feel good about this. We can issue our own certificates. We can be our own certificate authority, send those out to Jenny and her team so that they can go to each individual organization and register automatically for that. And we have profiles set up, and we'll get into other discussions about that. But like, it's not just a Carequality thing. It's not just in the networks. Like, you can utilize this for your own personal networks as well, your own personal growth in your EHR, your company, and how you distribute clients and secrets and utilize it for many different use cases as well.
I think it decreases it allows third parties like myself, whether it's a patient access use case or a treatment use case or future states, payment operations, public health, to onboard quickly, but also it decreases the burden on the EHR vendors or the FHIR server vendors. I mean, there's a lot of administrative work that rolled down to the EHR vendors under Cures Act because I don't pay Jason to help me onboard, but I'm going to send him 100 emails and lots of questions every day about all these organizations and how to register and who the contact is and where to find the person and what's the timeline and when am I going to get authorized. So I think it takes away a lot of that.
Great. Did you have anything to add, Libby? It looked like you were leaning forward, like you were just.
No, I'm just observing the back and forth between Jenny and Jason.
It's
Do it
something that
nicely.
everyone should say, it appears. You guys should have your own show. So, Jason, I know you wanted to specifically talk about other concerns outside of client dynamic registration that you thought were important to go over, and I want everyone to hear those. So I'm just going to ask an open-ended question and see where it takes us. And so what do you have for the group here?
All right. Yeah, I mean, I guess it wasn't so much outside of UDAP. I think it was just things that every implementer should start thinking about when they start utilizing UDAP. I kind of started with it in the previous question or previous answer. First thing that we realized, right, is like, do you have, what's your client maintenance strategy when you do this, right? Like, you could get flooded with, what's it, 20,000? There could be 20,000 clients that register at your endpoint. Can you support that? Can your database support that, right? Secondarily, like, can your customers support that? And then other pieces after is like, okay, 20,000 people registered. Now what do I do with all these people? How many of them are still actively being used? Should there be some kind of governance on that? Like, what are your policies for that client management? How are organizations maybe going to turn people on and off? How are you going to determine good actors versus bad actors, those that are utilizing it, those that are not utilizing it? That's a very important thing that we started to look at right away when we started to do this, because like we said, that can be a large number, especially if you're, Commonwealth and Carequality, put all those together. Like, there's going to be a lot of registrations that could occur at your organization, especially if you're at a bigger organization that has a lot of population that traverse, the United States. It's a very important thing. So think about your client management at that point. The other part is just like, what are your, what we call them profiles, right? Like, how are you gonna, what does each profile look like? If a client's coming in and they're saying, okay, I want to do patient access, and I want this scope and that scope, and I want all this, what are you actually gonna grant them, right? Because you're the server at the end of the day. You get to make all those decisions of what you're going to grant them, what your scope profiles look like, what your access profiles look like. Who gets access to client credential grant, who doesn't, who has to do authorization grant, who has to require Pixie, who doesn't have to require Pixie, all those different pieces. And that's a very important piece of this automatic registration, because when they come in to register, they can request everything that they want, but you have to determine what you want to give them. And I think that's a very important thing to think about outside of the nuts and bolts of like, how does this specification work? And it's something we've had to think about too, because like there's so many different we talked about payment and operations before this, right? How are those going to fit into your methodologies and those types of things? So those are things you can think about as an implementer that is starting to move forward here. And I don't know if that spurs anything else, but those were the first two I wanted to cover for sure, to make sure that people started to think about those as they were implementing.
Yeah, that's a very good point. A lot of the aspects, I mean, technically UDAP solves a lot of problems and offloads them onto your policies, which is wonderful because your policies have all been well written, well researched, and thought about, right? Everybody spends at least half their time on governance? Right. So now you should. Because as Jay said, I can go to your server, I can say, hi, I'm Dr. Bob, I want everything. And you can say no. Or you can say, you have this much because you work for this organization, so on and so forth. And a lot of organizations miss that whole policy aspect. It's just because somebody asks for something doesn't mean you have to give them all of it. You can give them part of it, you can give them none of it. Or you can say, you know what, we trust you. Because we all know how well that works. And that's the biggest thing. And to tail on to that, when you're dealing with individual patient access, right? Because we don't have something useful like a national patient identifier, because why would you want one? You're doing demographic matching against your record. So they send you, hey, this is who I am, I want access to my information. You have to take that information, send it off to your server to say, okay, yes, they actually are who they say they are, we trust them, that nicely matches. Or it doesn't match quite nicely, maybe it's only an 80% match, do you still give them access? Or they're a patient representative. Hi, I'm so-and-so's aunt, I take care of them now. I'm so-and-so's niece, I take care of them now. Do you give them access? And this makes the policy aspect of it much more interesting than the technical aspect, because there's FHIR IG. You can go out and implement UDAP. There are reference servers. It's out there. The governance aspect is going to be much more interesting as you try to work out how you're going to make this work with your organization, with your data, with your policies. And as you implement it, you can't just say, well, we'll think about that later, because everybody has been, and this is where we are. Anyway.
I think it's been a little disappointing to date, though, with UDAP, because the first time we started, or I was introduced to UDAP, was within the FHIR work groups within Carequality, so in the early testing days of it. So we were testing against it, we understood it, and we did a certification at ENAC, and there were only 2 other organizations besides from us, Z Omega and One Up Health, that went ahead and did like a UDAP. It was an annual certification. And so I think the biggest thing is, even though we're talking about it here on stage, there's not enough people who've actually started to look at this, implement it, play with it, do whatever they need to do. So that's kind of a call to action to the room. If you're going to participate in national exchange, and this is part of the FHIR IG, your organizations need to get familiar with this workflow.
So can we just go back to a comment that you made about what I interpreted was the burden on the server side to be granting authorizations. Can't something be done on the client side to vet who is going to be requesting what, so that the server has less decision-making to worry about on their side?
Yeah, I mean, I think the third part that I didn't get into right away is certifications, right? It's part of the registration. You can also send in different certifications. And one of the certifications that I've seen, I think Carequality has right now, is for individual access services. You can basically say, like, hey, here's all the... Fix that as I go. There's kind of a questionnaire basically says, like, okay, for this individual access service, what does the app do? How is the app funded? What does the app do with the data? Those types of things. And if you can pass those certifications along, that may give the user that's trying to access the data better workflow experience, right? Because they don't sell the data. They're funded properly. They check all the boxes to say, yeah, this is a trusted organization. I'm not going to give them all these big red flags during their authorization workflow, right? They'll just say, hey, this organization's accessing this data. You want to authorize yes or no? Yes, I do. They say they don't check any of those. Now you get to that authorization screen and you're like, hey, I don't know if they sell your data. I don't know what they do with your data. I don't know how they're funded. I don't know anything about these guys. I don't know how trustworthy these are. You can still hit yes or no, but now you kind of are fully educated by whomever to say, like, I don't know how much you want to trust this app. So if you click authorize, I mean, this is all on you now.
You just described the consumer workflow. Like,
That is the consumer work, yes.
I as a user see if I click through.
Right, but those certifications are ways to kind of help inform the server of, like, what you are, how are you a good actor, right? You kind of talked about how can we help clients out, or how can we help servers out? Like, that's part of the governance that Carequality can have, right? Like, as a certified vendor in Carequality, you can say, okay, I check these boxes and I can send this Carequality certification along, and that guarantees you that you will at least get this minimum right of access, right? Because you have this certification. All those pieces are there to be utilized, but we haven't implemented those yet. And I think the one thing I want to call out a little bit with this is, like, the UDAP specification isn't a replacement for access, right? It's just a way to make people be able to ask the question, right? That's how I always refer to it. We're giving them the right to ask the question. It doesn't mean we have to answer the question, right? Like, that's where the additional access comes in, your authorization workflow grants, what user rights they have in your own system to see confidential data, all those different pieces. UDAP and that specification is really just, how can I get the right to ask the questions? I get my client ID, I can start asking questions, and then you still fall back to your tried and true workflows to say, okay, do they actually have access to this data? Can I actually return this patient's meds for this user, yes or no, because you still have to do the authorization, you still have to make sure they sign in with their portal credentials correctly, whatever it would be. You know, there's still separate ways, like UDAP helps get you there, but it doesn't solve that side of the equation.
For me, the thing would be the most helpful for my organization is not actually the organizations that are live on Carequality today, but like the 3,000 other EHR vendors out there that haven't even like launched their R4 FHIR API. And just thinking about what it took to register for the existing EHRs we're connected to today and the payers we're connected to today, and thinking about what it's gonna be like for all these small specialty EHRs or the ones that like really do not have the regulatory teams and IT teams to implement Cures Act updates the way they need to and onboard my organization the way I will demand they should. That's what UDAP can solve. If like all those organizations onboarded to Carequality and then I could dynamically register, it would save me 2 years of my life. Yeah, 2 years.
Sorry, I got distracted by some random noise down there. So I want to ensure that we're getting the other end of the panel involved here. In our first implementation guide, we speak to having to support U.S. core resources. This is aimed at Mary Lee or Labib. What other implementation guides do you think we should be going after? Should we support after U.S. core?
Well, I don't know that I know the exact answer to that question, but I'm going to translate it into my world in terms of use cases.
Sure.
I think that when I was listening to the group, the panel before, and they were talking about the care coordination, and they were talking about trying to solve this problem around minimum necessary data, I think that, to me, one of the big reasons why FHIR is so important moving forward and why we really need many of you in this room to join up and participate is that we need to move to more granular, specific clinical data or data queries and stop just only having the ability to pull very large clinical documents back. Because when we move to FHIR, we are in a world where we can be more targeted in terms of the data that we ask for. So I think that we're doing 300 million documents a month plus. How do we move from IHE, XCA-based exchange to FHIR? I think one of those is these new use cases that are coming on board, the new opportunities to bring in a greater number of stakeholders that are involved in the care of the patient, to the party here of national exchange. So I think that's really important. And I'll turn it over to you.
Yeah, I'll kind of extend the topic that you're talking about. I do think, I trust that, Dave and Jason are going to write a really great implementation guide, right? Like our team is not really worried about, are the technical details going to be figured out by the time we are going to be starting to implement FHIR. So for us, we are ready to invest, we're ready to build our FHIR gateway, we're ready to receive and provide FHIR back out to all implementers. To us, the primary question is, it was such a long journey to get to kind of add on to what Jay's saying, it was such a long journey to get to a point where we are just now receiving treatment documents from most people who are implementing. What is the path going to look like to get to a place where we are kind of where we are today, but with FHIR instead? That's the really big open question for us. We have a customer who is all of their healthcare data is stored in FHIR. They don't want anything to do with CCDs. But then in order to participate in the framework, we had to then convert their FHIR data back down to CCD, which is, in my opinion, kind of a entirely backwards path of how we're supposed to be handling healthcare data in the first place. So to us, the primary question is to the folks in the room, what is our path forward to getting to a point where we are all ready to start talking FHIR instead of sending big clinical documents back and forth?
Right, but the pieces are there, right? Like a lot of the pieces are there. Most have, some kind of FHIR server right now, whether it's DS2, R4, along the lines. I think, Bill, the answer to your question for me for US Core is like US core is the minimum data set, right? Like I think everybody, maybe everybody hasn't heard this. US core is like the minimum data set. This is the minimum data you need to provide on your server to meet US CDI version 1 or version 2, whichever version you're trying to meet. That's the minimum, right? So that's the floor. So like, how do we keep moving that? I mean, the government's gonna move the floor for us incrementally, but like, how do we make sure that a lot of the shoulds are actually being supported, right? For the different searches, you know, it's more than just the must support elements, just the required elements. How do we get that additional depth of the data in FHIR? Because it can be very powerful, right? Like, you know, Dr. Miller, a lot of people are shaking their heads, oh, I can get discrete data, I can ask for the specific data I want. That's great, but we need to make sure that it has the depth and the quality of it there as well, right? That depth and quality don't go away with FHIR. Like FHIR doesn't solve that per se. We hopefully that it's a little bit more standard so that everybody's, whatever Alan said, everybody's implementing their own standards, but like, it's still the floor, so we need to keep moving that up. We need to keep saying, okay, how much data can I actually put in this? I'm not just gonna look at the differential view. I wanna look at the full view of this resource, right? I have all the must support elements. What are the other things I can contain? Obviously, you can look at US CDI and see where that's going, but like anything you can do to help for your organization to make that as rich and as in-depth of a resource as you possibly can, I think that's where we need to move after US core, is to say, we have the minimum, how do we get more to the maximum of those same resources to make sure that all the data is being put into those resources that an EHR potentially has?
You know, it's interesting to think about it because I feel like the patient access use case is probably the most mature for FHIR because it's, you know, there are production APIs or people calling it, it's in use, you're seeing data flow, but it's very much these patient access APIs are specifically scoped to US CDI version 1, and it's not gonna go beyond that until the government mandates something else. Like that's what I've heard from a lot of people that, no, we're not even thinking about V2, V3, and really people should be thinking about V2 and V3 in the patient access APIs because these are production ready APIs and you can use it as a test bed to expand how do you prepare the data and expose it, especially in light of the all EHI requirement.
I think one thing we also need to pay attention to is what your use case within Exchange is. Because if you're looking at payer and healthcare operations, you're looking at the Da Vinci FHIR IGs. Mm-hmm. You're looking at the Karen if you're looking for patients to go directly to the payer. You're looking for bulk data if you're looking at population health or, again, payer to payer if they're going to want to do large exchanges. There are all kinds of things that we could cover in the last 5 minutes we're up here. But really, it needs to go beyond, okay, well, I have to do US core. That's in regulation. We need to look at, okay, if we're doing payers, if we're doing providers, we're doing what we're doing, how we can make that better. And it gets down to long-term care, right? The ELTSS FHIR IG is out there. It's for long-term care and social supports. It's a smaller one. It's on the ONC website if you want to go find it. But it covers off these. Start looking beyond what we absolutely have to do in regulation and start getting into what use cases do we want to support? What of our population do we want to support? And finding the FHIR IG that matches that and implementing it.
Yeah, cancer IGs as well. There's cancer IGs out there now as well. I mean, a lot of them build off of US core. So like if you can do US core, you have US core plus, as in-depth data as you can. And a lot of these other IGs just kind of fit in there pretty well, especially from a profile standpoint. Everyone's got their own little nuances of how all the APIs work together, but like from a data standpoint, a lot of them have a lot of consistency and say, oh, well, this builds off of US core, this builds off of US core, so that can definitely be a great foundation for everybody. And as Jenny said, like the call to action, or like I would challenge everybody is to say like every year, like this, right? Like the next version of US CDI comes out as a draft. Then it gets published, then US core goes through their thing, then they publish the next version. So every year, put that on your roadmap, right?
Yeah.
Get to V2, get to V3, get to V4, keep filling those gaps in as US CDI Plus and all those come along, evaluate those as well. But like build that into your roadmap so that every year your US CDI is getting to the next version. As SVAP comes out and increments those versions, you're just keeping up with that. So you're building as rich of a data experience as you can for your APIs.
You know what we're going to lose with UDAP? I have one critique.
That personal touch of sending 2,000 emails a day?
Yeah. Is
You harassing me at every conference I go to?
I do that. Like, Jason, I see you. Is that I don't get to ask, like, I always ask organizations of, like, I try and gauge where they're at in adoption. Like, are they just going to do what's stated as is? Or they're like, no, we're going above and beyond. I'll lose that sense. I'm going to have to stalk them in another way. But, like, that's a big thing, is kind of saying, okay, these organizations fall into the conservative bucket. These are the progressive buckets. And that helps me think about how to prioritize actually which organizations are featured within our app. Like, I want to bump up those organizations over the ones that are like bare minimum, check mark.
We could always push UDAP as part of their capability statement to put like progressive or not progressive.
Yeah.
If that would help.
I think that needs to be in the Carequality directory.
Put that in there.
Alan, can we get that added?
Yeah. Well, to me, the new directory is critical to helping kind of drive adoption, because I think those of you who are implementers out there or from an implementer, I feel like we're flying blind a lot right now, trying to make decisions, where do we invest? You were talking about investing. And the more that we can see who is participating, who are the folks that are adding FHIR endpoints, the more that's going to create gravity, and hopefully a year from now, when we have this panel, we'll be able to be really focused on those folks who spent a good 6 months, 9 months, ramping up FHIR and talking about how much information we exchange via FHIR next year, right?
This is the benchmark.
Back to the call to action.
We'll be here. We'll tell you what we think.
I, for one, am super excited to be talking about actual implementations of FHIR, or the potential thereof, next year. This is the second time I've sat up here talking about implementing FHIR and socializing it. Yes, next year, let's definitely set that as a goal to start talking about our successes with implementing FHIR. Sorry for distracting me with your finger. Cat with the shiny object. So we only have a few minutes left. What? Oh, wrap up.
Wrap up.
Oh. I guess we don't have a few minutes left. Any closing remarks from any of the panelists before we get booted off stage?
Yeah, I think with FHIR, as will be the case with any other use case or any other new workflow that we introduce within the framework, we face this kind of chicken-egg situation of like people don't want to implement this new thing until there are other people who are also implementing this new thing, so it's not worthwhile for us to work on it. And so I'm curious kind of what other panelists here think the shortcut is to solving that chicken-egg problem. There is regulatory pressure on other things, but not necessarily a lot of regulatory pressure on like, you should be doing FHIR at this US CDI level. There isn't a lot of like, a lot of real.
I mean, I
As
think
we
the
go to
writing's
second half of this panel.
the writing's on the wall about the regulatory piece, right? If you're following the TEFCA framework and the FHIR roadmap and all those things, I think the writing's on the wall. But to your point about implementation, like there are people implementing it. Right? Bill and I have an email about TEFCA stuff, about doing some pilot things there. Like there are a lot of people that I have worked with that have implemented this process. And I think my closing remark is to look at the UDAP specification for your organization and say, okay, I know how it can help in Carequality. How else can it help me, right? Help me as an EHR, help me as a company succeed in my FHIR landscape. And I think if you investigated that a lot, I think you would really find that it can be useful in many different ways in Carequality and beyond.
All right. Well, I think that's it. The clock struck 0. Thank you, everyone, for your time today. Really appreciate it. And yeah, let's get off the stage.